Good morning, everyone, and thank you for joining us today. This webinar is brought to you by AlterG. We are the makers of the anti-gravity treadmill. I am pleased to welcome today's presenter and a member of the AlterG team, Brendan Rickert. Brendan holds an MS in exercise science and nutrition from Sacred Heart University. And prior to joining our team, Brendan was an exercise physiologist at Sacred Heart, where he taught undergraduate exercise science and worked in the Pioneer Performance Center, where he used 3D gait analysis to improve patient outcomes. His primary research focused on musculoskeletal and physiological changes when running in reduced body weight conditions, specifically in the AlterG. Brendan is also a cross-country and track runner competing in distance, road, and track races. As you can see, Brendan comes to us with a wealth of knowledge and experience, and we are delighted to have him presenting today. A few housekeeping notes for today's webinar. Brendan will be answering all questions at the end of the presentation. To ask a question, please use the Q&A or chat box at the bottom of your screen. And finally, for those of you who are not able to join us for the full presentation, we will be sharing a recording of today's webinar in the coming days. Brendan, we're ready when you are.
Awesome, thank you, Amanda. And thank you all for being on the recording today. This is my first time doing a webinar, so it's a little bit different. But as Amanda said, please submit any questions and she will be viewing them. And if anything comes up during the presentation, she'll be happy to interrupt me. And I really do encourage the questions. I tend to do a little bit better with them. So moving forward here, as you can see, as you signed up for today, we're looking at the 4 gait metrics that you can measure when working with neurological disorders and diseases. So these are the things that you're going to be able to do right in your clinic. So as Amanda, there we go. As Amanda said, a little bit about me. I have a master's in exercise science and nutrition, as well as an MBA. That's a little bit more recent. I also have my certifications as a certified strength and conditioning specialist and exercise physiologist from the NSCA and ACSM. So back in my undergrad days, or rather graduate days at Sacred Heart University, we had the fortune of being able to purchase a unit back in 2011, and I had the pleasure of doing my master's thesis as well as several other studies with it. And for those of you who have an AlterG, you can certainly appreciate the value of having one and being able to utilize one. And for those of you who do not have one yet, it's really a great tool. And I'm not just saying that because I work for the company, it's because of my experiences working with the product. As Amanda mentioned, I worked at Sacred Heart as an exercise physiologist. I also coached as a head coach at Fairfield University for cross country and track. And I've been working with AlterG for about 7 months now, and it's been fantastic. So today we're going to cover, first I want to define neuro patients and what that's going to entail for today's discussion. And it's quite a broad topic, so that's why I wanted to kind of focus that in a little bit. We're going to look at the 4 gait metrics that we're going to cover today, as well as just understanding gait patterns. And I do apologize if this is a little bit of a review for people, but I just like to kind of start from the base and build up. We're going to look at two different research studies, a case study, and then developing protocols. And I'll be happy to interject some of my personal experiences as well at the end if time allows. So let's hop right into it. So our neurological disorders can be defined as diseases of the brain, spine, and nerves that connect them. And the list I have below is certainly not an exhaustive list. It's some of the many that will fall into this category. And I'm definitely not a neurological disorder or disease expert. So I do apologize if I misspeak at all during this, and certainly don't want to offend anyone who does a lot more research on it than I do. But I'm just going to connect my specialties of gait characteristics to neurological disorders and go from there. Okay, so the metrics that we're going to look at today are going to be gait, or rather cadence, I should say. And normal cadence for a healthy individual, healthy adult individual, is about 110 to 115 steps per minute. We're going to look at basic support, and within this category, we're going to look at steps, stride length, duration of double support, and width support. Step length is defined as toe of one foot to the heel of the opposite foot. which should measure between 26 to 30 inches for women and men respectively. And that's going to be just based off of height and leg length. And again, these are just the averages. Stride length, it should be twice the distance of the step length. That's defined as one heel contact to the same leg's heel contact on that very next step. So that's how we define stride length. Stride width is 7 to 9 centimeters apart, and that's going to be from the heels of the feet, and these again are the averages. We're going to look at foot strike. So for foot strike, it should be a heel to toe pattern in a healthy individual. From a frontal plane motion, we're going to see some pronation. Some pronation is good. And the toes should mostly line up with the knees. In other words, you don't want that winging out or those duck feet that we talk about. And anything more than 7 degrees is considered outside of normal gait metrics. And lastly, symmetry. And this is probably the easiest category to define as just simply, as the right leg functioning the same way as the left leg, and how those two are linked and how they're going to function with each other. So this is your typical pictogram of a walking gait pattern. I'm not going to go through all of this. I just wanted to point it out. But this is what we're looking at when we're talking about gait. All right, so currently in your practices or in your facilities, and I'm not sure with everyone's background and what they're able to do and collect, but we have basically 4 different areas of how we're going to collect data and give it back to your patients or clients, whoever you're working with. Our first one is visually. So this picture here is just a typical, physical therapy picture that you would imagine when you're working with a patient, or that you do work with a patient, where the therapist is working with someone who's walking. They might have assistance such as handrails or a walking device of sorts, and you're giving verbal cues back to them. So they're not able to see what they're doing, which is totally fine. Everyone has restrictions into what they can do, and obviously with treatment sessions being a certain amount of time and insurance, you don't have a lot of time to give that feedback. So visual is going to be your #1 way of giving that feedback. Video is another way, so either using a computer and a camera, or just simply your phone and the apps on it. So things such as Coach's Eye or Technique or Dartfish are all available to you. They're great tools, and it's nice because you can film someone doing a movement, in this case gait, and then show them what they did. You can even annotate on it and give them that feedback that they need, that they're trying to accomplish a better gait pattern with. So it's a really great tool for feedback, and certainly something, if you can use it in your clinic, you should try to use it as much as possible. And then we get more into our research grade type of items. So our force plates, this is the ATMI treadmill that has a force plate built into it, which is a very super sensitive but highly accurate product. You have your 3-dimensional motion capture system, so you have your infrared cameras with the markers, and you also have your IMUs that you can use. And those are typically found in your university or research settings. Not to say that they're not found in physical therapy settings, but they tend to be a little bit higher cost and a little bit more tedious to set up. So from a physical therapy standpoint, they might not have the ability to work with these great tools just because of cost and time. So the 2 that I'm going to focus on today, in particular when it comes to measuring these gait patterns in patients, are the visual and video options that we have available to us. So a couple other things within this as well. So just a couple tests. We have our visual tests that you can do. So your time to get up and go, your dynamic gait index, which is a little bit more of an expanded time to get up and go test, which also includes directional looking and includes a step up component and a step down component. And it's kind of more functional, and I like functional tools that you can use in the clinic, because ultimately, as great as it is that someone can walk down part of your clinic that's a tile surface or a carpeted surface, they might have to be out at a graduation ceremony for their son or daughter, their grandson or granddaughter, and they have to go on grass or in gravel and things of that nature. So you need to try to throw as much at them within a safe environment that they're able to effectively use it in the environments that they're going to need to be in their daily living, especially with neurological disorder patients who have a more difficult time ambulating. All right, so the first study that I wanted to go through, this one dealt with Parkinson's patients. So this was actually done right at Sacred Heart University when I was there. I did help out with this study. I didn't more so setting up the patients than actually writing it. But the title, as you can see, does positive pressure body weight support, alter spatiotemporal gait parameters in healthy and Parkinsonian individuals. So this study, so Parkinson's, let me just back up a little bit here. Parkinson's, for those of you who don't know or just need a little bit of a refresher, when it comes to gait, they have a shuffling gait pattern. They have fenestrations, tremors. They tend to have a little bit more of a hunched over torso or even upper torso, where they're looking down as opposed to up. They might have some atrophy, but just like in most cases of neurological disorders, even within Parkinson's, there's great variations of who or what their disease state is and what their issues might be. And within this study, they used 10 healthy, 10 healthy patients, and then 10 with Parkinson's disease, and those were varying stages of the disease. So it's a little hard to quantify because of the differentiations. But what we found, or what the researchers found, I should say, I say, but what they found was that a one-time intervention, so the study was one time, that started at 10% body weight support and went down to 40% body weight support. They had lasting gait characteristics afterwards. And how did they measure it? Well, on the right side of the picture here, you can see our gait right mat that, or one that was similar to that was used in the study, which is a 10-foot or 10-yard long mat that measures gait characteristics, so it's measuring footfalls. And they measured them before the intervention with the AlterG, went to the AlterG, and then came out and they measured 5, 10, and 15 minutes post-intervention. And after that intervention, they had an increase in their walking velocity and an increase in cadence. So they had positive effects that lasted for 15 minutes afterwards, with just a one-time session. They did also measure through video capture, the sagittal and frontal views of the gait characteristics within the AlterG, and they didn't find any statistical significant differences. But overall, the conclusions were there appears to be a generalized effect of treadmill training on overground gait mechanics after one single session. So think about the typical patient that you might have come in your door. They're not assigned one session to you, especially for a neurological disorder. They're going to get, maybe 5, 10, 15, 20. So if a one-time intervention could have some effects outside of the AlterG, which is important, again, we're talking about that functional training, then imagine what you can get over a 6 to 8 week span working with this individual. And that's kind of a far statement for a one-time research study, and especially with this population. But the idea is that, when I worked with the AlterG, I was never afraid to put anyone in it because of their limitations to get in and out of it. Because I knew ultimately that if they were able to get into it and exercise, it was going to help them. And it's not because the AlterG is this magical tool, it's because that we know exercise works and the AlterG allows them to exercise. And that's what this study is saying, just a one-time intervention will have those lasting effects. So just a quick video here. This is not part of the study. This is from someone else who has an AlterG in their space. And you can see this is what a typical Parkinson's patient's gait looks like. This is the first day. So you have that shuffling gait. You can see that their torso, they're leaning back a little bit. Actually, in this case, they're holding on to the side of the treadmill for support. And they're walking on their toes, and that might be a product of how much body weight support they are currently having. And you can see the progression 4 weeks in. I don't know if you can notice, but you can see that the treadmill's on a little bit of an incline here. But now you're getting more of a typical gait pattern where they're walking heel to toe. They're not having that shuffling gait. And in this case, this person actually progressed to running, which is pretty significant for anyone that has a neurological disorder, and certainly inspiring. All right, so on to research study number 2 here. So this one was involved with children with cerebral palsy. So a little background: cerebral palsy, typically, or I should say, the most common type of cerebral palsy is the spastic condition, which affects about 70% of those with cerebral palsy. The physiology behind it, or the pathophysiology behind it, is damage to nerve receptors leading to the hypertonia of muscles. And this is specific to your hip abductors in a lot of cases within the spastic condition. What we know about this is that the tone, the issue of this hypertonia, is velocity dependent. So the faster the movement, the more likely there is to be that hypertonia and that spasm causing that disordered gait. So what a lot of interventions will entail, and at first we'll have the individual to walk slow, because that will decrease the velocity of that movement and ultimately decrease tone. In this study, and I'll show you in a little bit about their interventions here, the idea is that if you reduce gravity, you're going to be able to reduce the speed of the movement. Therefore, you can actually increase the walking speed, which is going to allow for more normalized gait, both in and out of the AlterG. So in this study, they used the Pro series, the Pro 200 series, or now the Pro 500 series. So just to give you an idea, it's a little bit bigger of a treadmill, but the children that were used, they had a median age of 13 years old. They used both boys and girls. And the intervention was over 6 weeks, twice a week. And what they did, in each week, they decreased body weight support. So they started at 40% body weight support and worked their way down to 10% support. So they increased resistance as they went on as a part of their intervention. Each session was 30 minutes long. And what the nice part about this study was, that I found to be really important, was that during the 30-minute sessions, they allowed the subjects to take a break. So the 30 minutes was only the time that they were spent walking, but they were allowed to take breaks as needed. So if they were out of breath or they were tired or whatever it might be, they were allowed to take that break. And why I say that's so important is because when you get some of these compromised individuals into the AlterG, they can do a great session, but my concern was always, when I was working with patients that were a little bit more low functioning, my concern was, well, how do we get them out after they have a session? They went from being on the couch and basically walking to and from the bathroom, and that was the extent of their exercise, to walking for 30 minutes. We need to get them out of the treadmill in a safe manner. We need to get them into their wheelchair or back to their walker. We need to get them in and out of their car safe and in and out of their house safe after that intervention. So I always encourage rest breaks, and the best way to do that was actually having patients increase the body weight support, maybe down to 30%. So in other words, be 70% lighter or 20% or 80% lighter. Actually have them physically sit back into the shorts and take a break. They were able to catch their breath. They were able to allow their muscles to relax a little bit and just kind of get their feet back under them before they would continue their session or get out of the AlterG. So just something to keep in mind when you're thinking about protocols. And I'll mention it again down the line, but that's why I like that particular part of this study. But going back to it. So yeah, after the 6 weeks, they saw a walking speed that was increased, their cadence was increased, they decreased their double support phase of the walking cycle, and they reduced their balance issues, which all are great things, no matter what type of issue you might be having, but especially important in neurological disorders. So the conclusions of this: it is feasible to use a lower body positive pressure treadmill, so in this case an AlterG, to improve the walking performance, balance, and strength of children with CP. So again, this is more in line of what you're going to be seeing as a physical therapist, for those of you who are physical therapists, that you're going to have 6 or 8 weeks to spend with someone in multiple times a week. My wife's a physical therapist, and she wanted me to mention one of her patients that she's been seeing who has cerebral palsy, and he comes in twice a week. On Tuesdays, they spend 40 minutes on the AlterG walking and, again, taking those breaks as needed. But then on that Thursday session, because of that muscle tone, that hypertonia is actually decreased from the initial session on that Tuesday. The Thursday, they're out of the AlterG and they're working on more functional exercises outside of it, so that way it's more applicable to their daily needs and daily tasks that are needed. So just one little anecdotal thing there that she's experienced with someone with cerebral palsy. So I'm just going to skip ahead here on this video. This is a good video. It's 3 minutes long, but I just want to skip ahead to right about here, just to kind of show what a cerebral palsy patient can look like and what their limitations are.
Victoria had to wear, in order to walk, had to wear hip brace, leg attachment, for she has
So you can watch that whole video on our website, or on our YouTube page rather. It's not a long video, it's 3 minutes long, but I just wanted to point out a couple of things there. She was able to walk in the AlterG, one, because she wasn't afraid of falling, which is a huge concern with anyone with gait abnormalities, especially with neurological disorders. She was able to walk without that full body brace, the back brace, the hip brace, and the leg braces. She still had her AFOs on, which is absolutely fine and what we would commonly see, but she was able to get exercise, which is great, and she feels good. She feels like she's trying to improve a little bit, and that's ultimately what your responsibility is as a caregiver, as a physical therapist, in this environment. So again, just an example of the AlterG being a vessel that allows someone to achieve their goals. It's not because the AlterG is this magic wand here. It allows them to feel confident, and it allows them to achieve their goals, which is great. Okay, so a case study here, and I have a little bit of time here, so I'm actually going to talk a little bit about an experience that was personal to me, but I'll explain this case study. So this case study came right from the AlterG website. So it's someone who had a stroke. The patient was 93-year-old male. He had a stroke 2 weeks prior. Has a history of hypertension, macular degeneration in the right eye, PAD, and vascular claudication. Has a 2-story condo and balance issues. So kind of similar for those of you who are physical therapists, what you see almost every day. They have multiple issues going on. They have, the reality of where they live might be an issue, and you have to do several things at once in order to get them back to where they need to be. And that's part of the job, and that's part of the reason why the AlterG can be beneficial to you when you're trying to go through and give the best, highest level of care that you can. And again, strokes are different between all different people, and I'll explain my story versus this one in a second. But this case study, they did a timed get up and go test. They did the Berg balance score, dynamic gait index, pre and post. And what you can, I'll show you the protocol in a second. But one thing to note was that he had issues training over ground because of the calf pain, which was non-existent in the AlterG. So he no longer had this pain. He was able to exercise in the AlterG, and he was able to return to an independent active lifestyle afterwards. But you can see here from the scores, his time get up and go test improved by 3 to 5 seconds depending on which way he was turning. His Berg balance score improved, and his dynamic gait index was almost perfect after this intervention here. And this intervention was 9 weeks long, twice a week it looked like. And yeah, they started the sessions at 75% body weight. They vary between incline and speed, and duration as well. So another opportunity to use the AlterG in this manner to help someone get back to their daily routine. And just a little bit of my case study, personal case study I don't have on this PowerPoint. So I dealt with someone who had a stroke. They actually had a stroke 20 years prior to when I started working with them, and they still had spasticity in their leg and arm, really poor control of their body, just in general, wasn't able to talk. And he's someone that you would be very nervous to work with, just because you immediately think fall risk. You immediately think, how do I get them in the AlterG and out of the AlterG? And why I'm so confident in the AlterG is that I was able to get someone like him in and out, no problem, and progress his exercise. He went from being able to tolerate less than 15 minutes of exercise total to actually being able to get in a full hour session where he was walking upwards of 3 miles per hour at points at an incline, and doing some very small body weight exercise and balance drills. And that was over several months. And he was an example of where I worked at Sacred Heart. Obviously, I'm not a physical therapist. We had a cash pay business, and he was a cash pay customer, and he would come in 2 to 3 times a week for over several months, and you saw the improvement. And just because we know exercise works, the AlterG allowed him to exercise. Okay, so getting into protocols a little bit here. So whenever I think about protocols, there's several factors. First one is timeline. Well, how much time do we have to work with someone? And this is going to be based off of insurance. Do you have a wellness program for them to graduate to? And their at-home program, which we all know how well people adhere to their at-home programs. But that's the first thing I think of is, well, how much time we have to work with? And then I can start from there. So how do we start? Well, it all depends, and this is probably the most frustrating answer I gave to my students when I was teaching, because in this world, it all depends on every single person. As much as we try to loop people into groups, as I've noted and as you've experienced, especially in this population of neurological disorders, everyone's a little bit different. So I always err on the side of caution when it comes to starting with someone new. I like to make sure that they go, and I tell them this when we start. I said, I want you to leave the session feeling like you could have done more, and I want you the next 2 days to feel like you could have done more today, as opposed to doing too much on day one, having them have issues getting back into their car, and having them be too sore and too tired day 2 and day 3 after the session, where they're just not able to leave the couch or do what they need to do, because that's going to be discouraging to them. Because if they feel like, well, I went to physical therapy and Brendan had me on the AlterG here, and now I feel really sore and tired, that thing didn't work. It made things worse. They're not going to come back to you, and that's not what you want, and that's not what you want for them. So I always try to err on the side of caution, and then try to track between patients what your starting point is. Maybe for someone 50% body weight is where they need to start, but for patient B that walks in, maybe they can start at 75% body weight, and it's because they're a little bit more active, or whatever the parameters might be. But try to track on your own, not just through progress notes, where you started with other patients, because that's going to be a good indicator as to where to start with the next person that walks in the door. So some things that you can do to change the intensity. So interval training. And when I say interval training, I don't just mean adjusting the speed. I mean adjusting the incline and duration as well. It's a form of interval training. Use this to your advantage. I'd like to introduce one new stressor at a time, so I know what works and what doesn't work. And likewise, if you might have someone who has an injury after a session, and hopefully you don't, or they might feel a little extra sore, something along those lines. If you can say, well, we increase the incline on this session, and that's the only thing that we increased, well, maybe we did too much incline, so next time I won't do as much incline. But if you increase duration, increase speed, and incline, you don't know which one of those three factors was ultimately the factor that made someone so extra sore or potentially hurt. So I like to just introduce one new stressor at a time, so that way you can go back and objectively say, well, this was the reason why, so we're not going to do this next time. And then again, for those of you who have an AlterG, and for those of you who are considering one, you should use it to your max potential, right? I mean, it's a great tool. It's a great unloading tool for walking and running, but you can even, you can use it for a rest tool, as I mentioned before. You can practice balance drills, bodyweight exercises, and if you have the performance shorts, you can go laterally in it, or even just have them face laterally without the treadmill on, and then do those same balance and bodyweight exercises facing outwards towards you. Leverage the tools that you have in your clinic to enhance your patient outcomes. They're there for you for a reason, and try to give your patients the best possible care possible, and that's what the AlterG can do for you. You can even use the bodyweight support as a style of interval training as well. So maybe during the session you start at 75% body weight and you work your way up to 90%. Or likewise, if they start to get tired, but they want it, your goal today was to increase duration, maybe you start at 75 and you go down to 65, just so they can get that full session in and they can get that satisfaction of feeling like they accomplished something that day. Not saying that they wouldn't otherwise, but those little factors are huge. And then a couple other things. So in the research study, the first one about Parkinson's patients, we know that Parkinson's patients, among other neurological disorders, have a high level of success when they have visual cues. In that study, we didn't have them. We didn't have the VMS. We didn't have the Stride Smart systems hooked up to our AlterG. AlterG, before I started working with them, they came up with Stride Smart. They came up with a video monitoring system that allows for that real-time feedback, and it's just so important, and it links right back into the talk today with gait parameters. So this is an example of our Stride Smart software here. So we have a weight bearing. So this is how much support you're putting into each leg. And you can see the differentiations, 53% versus 47%. So it's giving you that information if someone's favoring one side versus the other. You have symmetry, so they're looking at step length, stance time, again, important gait characteristics. And you also have cadence. And cadence is, again, an important characteristic. And these are all ways that will give more cues to your patient or client that you're working with to change. You can say, hey, listen, you're favoring that left side up here. Try to get more pressure on that right side, and they can see in real time that they are putting more support into that right leg, and now they can get that neuromuscular feedback that they really need to have success. So that's why if you have an AlterG and you don't have the Stride Smart, it might be something worth looking to get into. If you are looking to get an AlterG, our new VIAs, it comes automatically with them, and it's a great tool to have. So it's something that you'd want to consider as to how best serve your patients and clients. And I think this is a great way to do so. And it's taking that aspects that I talked about before of using your visual cues and your video cues, and it's combining it right into the screen in front of you for your patients and clients to use. So I just want to do a quick recap here, and then we can get into questions. So as I mentioned, the 4 parameters that you should look at, and this is just because this is the easiest to look at when you're in the clinic setting, would be cadence, your base of support, your foot strike, and your symmetry. Those are easy to give subjective and objective feedback to, and also going to be one of your biggest indicators of overall success for gait retraining. Remember, every case is different, especially when it comes to neurological disorders. What one protocol will work with patient A may not work with patient B. Leverage the tools that you have. I always say this when talking with physical therapists. you probably have a hammer in your clinics lying around somewhere, and it's not to hammer a nail into a wall. It's to do internal external rotation at the forearm. So think about the objects that you have and how you can best utilize them, to get your patients the highest level of outcome possible. If possible, use objective data, because it's going to help with not only insurance but patient compliance. So that StrideSmart I showed you can be printed out as a report. You can put it into your EHR, and then you can also give it to your patients, and you can tangibly say, hey, listen, week 1, these were your gait parameters, but now at week 4, from using the AlterG, these are your gait parameters, and look at how much more close to normalized they are. So it justifies why someone comes to you. And not saying that they need a reason to do that, but it does help, because ultimately your practice is dependent on people coming in and being there. So if you can give them a reason to come in and be there and stay there, they're going to have other people that they know be referred to as well. So objective data, I always love. Track your protocols from other cases. Keep a file on hand that has similar neurological diseases and disorders, as well as other issues that you might see, such as like a knee replacement or hip replacement. But yeah, so that's pretty much our recap here. That's not my dog. I wish it was. But does anyone have any questions? I'll turn it back over to you, Amanda, for that.
Thank you so much, Brendan. I think that was definitely a lot of information, and I know that people are coming in with a couple of questions over here, so we'll go ahead and address those. And then you know what, it looks like there's a little bit of feedback. Brendan, are you able to mute yours in between questions?
Yeah, absolutely.
Thank you so much. If anyone has additional questions, you can ask them now, or and I'll go ahead and ask the few that are coming in. And then if you also have any questions after this, you can always reach us at info@alterg.com, or you can reach Brendan directly at brickert@alterg.com. And we'll go ahead and send you more information as well via email after this presentation. So Brendan, here's a couple of quickies, it looks like. We mentioned how visual feedback is especially useful when treating Parkinson's patients. Is there a way to see the movement of the legs while in the AlterG, in addition to seeing the symmetry and cadence data?
Yeah, absolutely. So, are you talking about, just to clarify, for the patients to see their legs, or for the therapist to see their legs, or both?
It looks like they're speaking directly about the therapist, but if you can answer both, that would be very helpful.
Yeah, for sure. So the AlterG has clear panels around it that allow you to see both sagittal views, posterior view, and a very small frontal view as well. That allows the therapist, more so the therapist, to see what's going on within the bubble, the bladder of the AlterG. So that is available for you as a therapist, as the clinician, to be able to give visual, verbal feedback, or even record video. If you have the VMS system that's included with AlterG, you can use that. Or you can take your own phone or camera and record as well. For the user inside the treadmill, so for the patient or the client that you're working with, they will be able to see only really the frontal view, so really just like their feet if they look down. But depending on if the AlterG has either the VMS system or the StrideSmart system, they will be able to see, if they have the StrideSmart, they'll at least see the frontal view. So there's a camera inside the treadmill that will give real-time visual feedback of the frontal view of the legs. And then if you have the VMS part as well, you will have a sagittal view and a posterior view available to the patient, again, in real time. So those are the two ways that you can certainly get that feedback that you need for working with, especially Parkinson's patients, but with anyone who has a neurological disorder.
Great, thank you very much. And then, is there a recommended age or size when using the AlterG for pediatrics?
So it's not so much an age as much as it is a size. We do have minimums. 4'10" is your, actually I think we can go a little bit lower. 4'8", I believe, is the minimum height requirement. And the weight is 85 pounds. There's a height and weight minimum in order to get the treadmill working accurately. As far as age is concerned, I think that's going to be a little subjective. You want someone who is going to be able to, understand the cues that you need to give them, as well as it looks a little scary. It's a different looking treadmill, so maybe someone who's younger might not be comfortable at first going in the AlterG. So that might be a consideration as well. But really, it's a height and weight restriction.
Fabulous. Thank you, Brendan. And it doesn't look like we have any other questions coming in at the moment. So I think we're going to go ahead and end this webinar. Thank you all for joining us. And as I mentioned, we will be doing a follow-up email. So if you have any additional questions or would like to speak with Brendan directly, go ahead and respond to that email. Brendan, thank you so much for your time this morning. We really appreciate it. And I hope everyone has a wonderful rest of their day.
Absolutely. Thank you.